I want to welcome everybody. My name is Kevin Stein, and I am the co-editor-in-chief of the Journal of Cancer Rehabilitation. And welcome to our first ever live webinar on the role of exercise in cancer rehabilitation. And you can see on your screen right now a link, a Facebook link in which we're live streaming. So if you know of anyone who's trying to join but is having trouble joining, please do shoot them that link. We've had an incredible amount of interest and excitement about this webinar. We quickly filled up our 500 allotted spots, and we even had a waiting list. So there's definitely a lot of interest in the webinar. We have participants from over 40 countries around the world. I think we covered 6 of the 7 continents, and we have large representation from Europe and the United States. I think Martin led the way with the Netherlands at first, and the USA caught up quickly, and then the rest of the world was catching up as well. And we have participants from exotic regions in Costa Rica, Bahamas, and the Canary Islands. And I think Nicole suggested the next time we do this, we're going to host it live from one of those locations. So we'll be reaching out to one of you attendees from those exotic locations. But again, I want to thank you all for being here. And on behalf of my co-editor-in-chief, Dr. Vittorio Mattioli, and the entire JCR editorial board, I'd like to welcome you all to this exciting live event. I want to spend just a couple of minutes before we get to the main event, introducing you to the Journal of Cancer Rehabilitation, which is a new journal which was started 2 years ago. It's an international peer-reviewed quarterly journal. So far we have 13 publications, and we're really excited about our future. As you can see, there's some important features of the journal. It's an open access journal, so anyone can see any publications that we make online. Articles go through rigorous peer review and are immediately published online upon acceptance. Authors retain the copyrights to their articles. I want to encourage all investigators to consider submitting your article at the link down there below. You can find the link to the JCR website. So again, please take a look at our journal and help us really promote the research and the clinical work that's going on in the area of cancer rehabilitation. I want to acknowledge the many members and the contributions of the JCR editorial board who you see listed here. So thank you all. Some of you are probably on the phone right now and watching us online, and I really appreciate all the contributions you all have made to the journal. I also want to mention one special initiative from JCR for early career and young investigators. So you can read what the initiative is right there. And if you are new to the field of cancer rehabilitation, I encourage you to consider taking advantage of this opportunity and submit your article to JCR. And now I'm going to take a moment to introduce our expert panel. We're really excited that these 4 individuals have agreed to participate in this webinar. It's really exciting to have them on board. The 4 presenters are in order of the pictures from left to right. Dr. Catherine Schmitz, who is a professor of public health sciences at Penn State University's College of Medicine. She is a past president of the American College of Sports Medicine. Dr. Schmitz chairs the Global Exercise is Medicine Governing Committee, and she is the founder of the Moving Through Cancer Initiative. Dr. Schmitz has published over 250 peer-reviewed scientific papers and has had $25 million in funding for her research since 2001. And in March of 2018, Dr. Schmitz co-chaired an international multidisciplinary roundtable on exercise and cancer prevention and control. So welcome, Katie. Our second person on our panel is Dr. Nicole Stout, who is a research assistant professor in the Department of Hematology Oncology at West Virginia University Cancer Institute. Dr. Stout is an internationally recognized expert and leader in the field of cancer rehabilitation and survivorship care. Her research publications have been foundational in developing the prospective surveillance model for cancer rehabilitation and survivorship care. We also have Dr. Morten Quist, who is an associate professor at Copenhagen University and a physiotherapist clinician researcher with over 20 years of experience in cancer rehabilitation, focused primarily on helping patients with cancer to participate in exercise programs. He's the co-founder of the Body and Cancer Program and founder of the Exhale Trial, a community-based exercise program for patients with lung cancer. And our last panel member is Dr. Martin Stuyver, who is a clinical epidemiologist at the Netherlands Cancer Institute's Center for Quality of Life. He has a background in physical therapy and has been involved in cancer rehabilitation and supportive care for over 20 years. In addition, he is a lector for functional recovery from cancer and its treatment at the Amsterdam University of Applied Sciences, and a senior lecturer and vice principal of the Master Evidence-Based Practice in Healthcare at the University of Amsterdam. So thank you again to all of our panel members for joining us and for all of our attendees as well. I also want to just take a moment to acknowledge the support of the many organizations and institutions that helped with the promotion of this event. They were a great help, and we appreciate all that help. And a few things to note before we start, just a couple of housekeeping items. We do have an hour and a half. We're beginning with the introductions that we're doing right now. Then we'll move to the bulk of the session, which will involve a panel discussion in which we'll pose 4 important questions to the panel, and they'll discuss those. And then we are going to leave time at the end for general audience participation and a Q&A with attendees. Please note that all attendees, all of you are muted except for the panelists and myself. So if you want to ask a question or make a comment, we encourage you to use the chat box feature. As I mentioned earlier, we are streaming this live right now on Facebook. We're also recording this webinar, and the webinar will be archived on the JCR website and will be available to watch asynchronously later for those who could not attend today, or if you want to watch it again. I also want to mention that we're going to have some polls that will pop up during the webinar, I think 3 or 4 questions. And just please feel free to answer those questions just to gather a little bit of information about you as attendees, who you are, where you're from, things like that. And then after the webinar is over, you will receive an email, I think tomorrow, hopefully, with a post-webinar survey to ask you about your experience with the survey, which will also provide the speaker information and contact information for our speakers so that you can contact them if you need to. And also the links that we discussed today for the archived webinar and other things relevant to JCR will be provided via that email. So unless there are any questions right at the beginning, let's go right into the expert panel discussion. Guys, you ready?
Ready.
All right. Here we go. Okay. I'm going to pose the first questions to the panel. Question number 1. There is a great deal of evidence that exercise is safe and beneficial for individuals with cancer, both during and after a cancer diagnosis. However, implementation of exercise interventions is complex. Please describe, from your unique perspective, what you see as the primary facilitators and barriers to the implementation of interventions in the various settings in which you work. And I'm going to direct this question first to Dr. Quist.
Thank you, and hi all of you watching or listening or whatever you're doing. Well, I will start out talking about my country's perspective. I live in Denmark, and in Denmark we have a rehabilitation law. And that means that every patient with cancer are entitled to get rehabilitation at least 3 months during either the treatment or after treatment. But still, these patients are not referred to rehabilitation. So even though we have a system that actually is free and it's mostly all municipalities in Denmark, there is a rehabilitation center, well, not all patients are referred to rehabilitation. And why is that? One of the key barriers and facilitators is actually the oncologist or the health professionals working in the ward where patients get treatment. We know not only from our own research, but from research internationally, that an active oncologist or health professional is more likely to prescribe exercise to their patient versus an inactive or doctor or health professional. And this means that if the patient doesn't have any, is not normally active, well, it's difficult for them to find a place to be active. And we know that even though that rehabilitation is not only exercise, smoking cessation, dietary counseling, etc., it's still exercise patients are asking for. So one of the things we did in Denmark was to get the oncologists on board in our projects. And to begin with, one of the main factors that we had to overcome was my patient is more frail than yours factor. So in the beginning, when we started doing exercise classes, some doctors or nurses said, well, of course, it's possible to do exercise with the patients you have because they are not as sick as the patients I have. So what happens over time is patients talk to each other in the waiting room, talking to maybe a new oncologist when they are getting treatment and telling the experience they have from exercise, and suddenly it all starts to grow bigger and bigger, like rings in the water. So what we did to get oncologists on board was to let them join the sessions where we did exercise. And in some cases, the oncologist realized that patients were actually more capable of having a higher VO2 max, being capable of lifting more in the machines. So joining a session actually made the oncologist aware of what these patients are capable of. After we started that in 2001, I began with lung cancer in 2009, and we had to start all over because these patients were in an advanced stage. And again, oncologists that didn't was on board in our project couldn't find it possible for patients with advanced stage lung cancer to be active. And again, we had to convince them that it was actually possible for these patients to be active by letting them join again. So whenever we out teaching about what we do, we are always meeting someone saying, my patient is more frail than yours. And last fall, I was in Portugal, and in Portugal, they are trying to start a new program for exercise for cancer patients during chemotherapy. And after showing a video of what lung cancer patients was capable of, and cancer patients with various types of cancer as well, the head oncologist from one of the hospitals told me that, well, Danes are probably more active than people from Portugal. So what could be a good thing to turn this over to is when you do have patients, you have to look into more how to prescribe and factors you have to be aware of. And I think, Martin, it could be something for you to go on with.
Yeah, thank you, Morten. I do recognize all those things that you mentioned, and specifically that my patient is more frail than yours statement. We do see that doctors are inclined to refer more more often the more fit patients, whereas we believe that it's the frail patients that might need the most support. Kevin, you just said there's a load of evidence supporting that exercise is safe and beneficial, and that there's still a huge gap between research evidence and clinical practice. And I think if you look at that from an evidence-based practice perspective, there's a reason why there are three fundamental aspects to evidence-based practice. It's the evidence on the one hand, and I think we have enough of that to start implementing exercise as a standard intervention. But then there's also the clinical state and circumstances that patients are in, and the patient's own preferences, values, and actions that they take. And I think if you are considering how to implement exercise in cancer care on a more fundamental level, on an organizational level, throughout healthcare and community services, this is something that you need to take into account very seriously. So we know from our own research, for example, in the PACES trial, where we try to use exercise as a means to mitigate fatigue and all sorts of symptoms that patients might have during chemotherapy, which, by the way, was actually quite successful also. We did find that there were several barriers for patients to participate in the trial and in exercise in general. And we also queried the patients who were not willing to participate in the interventions or in the trials, why that was. And what we found, and we've seen this in clinical practice as well and in different patient populations, is that patient factors are really important in this respect. So things like current health status, comorbidity, people's own beliefs and attitudes towards exercise and what they might gain from it, or how safe it might be, or how difficult it might be. And also very important social factors such as peer influence from important peers such as partners or children, and also, of course, again, the physician. So it's very important to have to address all those issues as well. And of course, many cancer patients have comorbidity. Many of them have other competing problems or psychosocial problems that compete with what we're trying to offer. So in order to not only implement exercise interventions, but also make sure that there's sufficient uptake, so people are actually joining those exercise programs, I think it's very important that we pay attention to those aspects. And what this means, I think, is that we need to have a very diverse sort of exercise programming with different levels of multidisciplinarity, different levels of supervision, different levels of qualification, of expertise, of the people supporting those programs or supervising the patients. And if at all possible, it should be as close to patients' home as possible, because we know that travel is a huge barrier. But then again, it's of course difficult to get highly specialized rehabilitation close to home. So there's all these trade-offs to consider. And I think if you want to be successful in not only implementing exercise, but only getting people to do the exercise and join the exercise programs, you need to invest in this diversity, and you need to have ways to communicate across settings to get people flowing from one setting to another, and have people who have very complex health needs start out in multidisciplinary rehabilitation and then slowly progress towards self-directed exercise or commercial gyms or community service and such things. So yeah, I think that's those are barriers and facilitators at the same time. If you take away those barriers, that would be a great facilitator. And I'm sure Nicole also has something to say on that.
Yeah, maybe some different thoughts that I'll share around some of the barriers to implementation and how I think we can overcome those. I think you and Morten have done a great job of articulating some of the personal factors and the physiological factors, right? The impairment, the frailty, the other personal factors around motivation. A lot of times we cite barriers just physically being motivated to and getting to a place where an individual can exercise. So they say things like, I'd love to, but I don't have the time. I don't have access to a facility where I can exercise. I have to go to a place, an additional place. That's very complex, and it adds a level of burden to the patient, to their family members. And so one of the things I think is very important is the idea of conjoining or co-locating the services, using rehabilitation or exercise professionals co-located with the centers where we are providing cancer care to begin the process of the assessment and giving the advice to the individual. right? It's great for the physician to say, you need to exercise, or the advanced practice providers, you need to exercise, go to this place and see this person. I think we see a large number of individuals not be able to accommodate the going to this place and see this person. So I think it's critical for us to have that interface at the point of cancer care, if ideally, if we're able, to co-locate the service. What I don't think that means we have a gym in every cancer center, although wouldn't that be great? I mean, that's a vision for the future. But I do think co-locating the exercise professional, the rehabilitation professional, to begin that conversation from a very specialized point of view is so much more effective at getting patient to buy in and to help to overcome those barriers of, where do I go? How do I do this? The other barrier, and we can't ignore, is definitely around the payment and cost issues. There's a fee that patients experience if they're going to go to a fitness facility. So we have to think of ways to overcome that, or there's a fee if they have to go to a rehabilitation center. And so I think there can be some interesting initiatives that we could think about using incentives, home-based therapies, as you said, Martin. How do we bring it to the individual in their home, as close to them as possible? Using video, using telephonic services to be able to enhance that where they are. So I think the better location of the exercise professional and the exercise advice, meeting the person where they're at, whether that's in a treatment center, whether that's in their home. But I think we're failing when we say they have to go to XYZ rehab center or ABC fitness center as a starting point. We should be able to start them somewhere, get them bought in, get them into a program, and then help them explore and find resources that are going to be most available to them to help to support. Katie, you may have even some further differing ideas on barriers and facilitators.
I do, Nicole, and as you know, we have a gym in the chemo suite at Penn State. So we have tested and successfully tested the co-location of these exercise professionals, and we see that as a real win as well. I would say that I think that there are 4 additional issues beyond what I have heard from my colleagues. The 4 issues being awareness, programs, workforce, and policies. And awareness and policy is actually kind of a bit of a loop, in that I think that this is one of those few areas in science where we have, over 700 different randomized controlled trials showing us the safety and efficacy of exercise for a variety of different clinical outcomes in people living with and beyond cancer. And yet, if you ask the average person on the street, your mom is going through treatment for endometrial cancer, should she be doing exercise while she's going through chemotherapy? They'll probably say no. So there's not an awareness on the part of the patient. There's not an awareness on the part of the clinician. And so policy can be partnered with that issue, because if we were to develop, for example, NAPBC is the accrediting organization for breast centers in the US. If there were a standard, an NAPBC standard that said you need to assess, advise, refer to exercise and rehabilitation at medically important points along the way for breast cancer, then it would have to happen for those breast centers to keep their accreditation. That forces the issue of awareness by having a carrot or a stick, whatever you want to call it. As to programs and workforces, there's a lot of work to be done, and all 4 of these things that I'm talking about are within the purview of this program that we've started through ACSM, called Moving Through Cancer. It is an international multidisciplinary task force that has a mission of getting exercise to be standard practice in oncology by 2029. These 4 issues are key in getting that to be the case. And in terms of programs, I absolutely agree with Nicole that we need to have more programs that are in more different locations. But in addition to that, we've got to be able to make clinicians aware of those programs. And so we have developed a registry on the Moving Through Cancer website. I'll put it up in the chat box so that you all know how to find it. We are in the process of trying to ramp up that registry so that there are more and more programs there for clinicians to refer to. But the final point that I'll make is one about workforce. We right now in the US, and I checked in with my colleagues from Europe, and they say it's essentially the same there, that the proportion of exercise professionals who are adequately prepared to work with cancer patients and survivors is vanishingly small. We need to do a better job of making sure that if somebody is a certified fitness professional, that they have some kind of background that at least tells them whether they should or should not be working with a given patient. And we need CME courses as well for clinicians to understand how better to talk to their patients about physical activity. One of the reasons that clinicians tell us that they don't talk to their patients about exercise is because it's an uncomfortable conversation. They don't know what they're saying. They get it confused with weight loss and with nutrition and with other issues. And if we want them to talk about exercise, we need to give them a script. We need to give them ways to talk to their patients so that it is easy for them to do so. I'll close there.
All right, thank you. Thank you, Katie. I'm going to share my screen one more time and pose the second question, if I can figure this out.
As you're doing that, I've posted the Moving Through Cancer information, the link in the chat box for everyone to take a look at.
Thank you very much.
Great. All right, so our second question to the panel is, given the challenges noted above, can you provide a few examples in which exercise interventions have been implemented successfully, noting what you believe accounts for this success? And a related question is whether we should consider exercise in cancer as a healthcare intervention or a lifestyle choice. And Katie, I think I'll direct this question to you first.
Yep, I'll lead us off. And so the answer to the second question is yes. And I think the panel is in general agreement that it is both a lifestyle and a healthcare intervention. We had a lovely discussion. The panel had a lovely discussion in prep today about, where do you see the success? And so, what does good look like, and where are the success stories? And there are success stories the world over, but they appear to be able to be lumped into three categories. The two most common are those that are programs that are funded by a foundation or charity, and programs that are funded as part of a research grant. So those seem to be the most common things that are out there. And then, and there are many, many, many examples of these. In the US, I'll note Maple Tree Cancer Alliance in Ohio and California, Livestrong, certainly in all 50 states, Fit Steps for Life in Texas, Carol Michaels' work in New Jersey, Two Unstoppable, which is a virtual program that started in the Washington, D.C. area and is now national, the University of Northern Colorado Cancer Rehab Institute, and the Move More campaign in the UK. So those are all examples of programs that are funded by some kind of charitable donations or foundation. And then there are a number of programs that are ongoing. My own at Penn State, Carrie Winter-Stone, Kristen Campbell, Kristen Dealey-Wright, Rob Newton, Paul Listeo at Huntsman in Utah, Mary Kennedy's work, Antonio Chesta Vargas's work at the University of Malaga in Spain. So there are examples all over the world of research-based programs. But of course, the problem with those programs is, and I'm going to ask very specifically for Dr. Quist to talk about this, but in the US, the issue that we have with a research-based program is that when the funding runs out, that's it, it's gone. There's no way for us to do this. That does differ in other places in the world, which is a fantastic thing. One of the questions that we pose to ourselves is, well, what is it that makes these programs go? Why does Karen Wonders have 30 plus locations for Maple Tree Cancer Alliance? And why does another program only have one? And honestly, it's, if you've seen one, you've seen one. It is the champion. It is the person who is willing to, just not willing to take no for an answer, and who will go back to the hospital board over and over and over again. What we are hopeful of is that eventually We have policy and we have payment schemes that make it easier for these champions to be able to get a yes out of the hospitals and the fitness centers that they're trying to work with. I think I'm tossing this to Morten.
Yeah, thank you, Katie. Well, I'll just get back to the Scandinavian model. As Katie said, in Scandinavia, we have a tax-paid healthcare system. So when we do a research program, one of our success criteria is if we can provide some evidence that what we do will benefit the patient. Well, in the best cases, the government or the healthcare system will take over the program and then it's implemented. And we actually succeeded with that in a program called Body and Cancer, and that was the one we started back in 2001. We published that in 2009, and it's a program, 6-week program for patients with various diagnoses during chemotherapy, and it consisted of body awareness training, relaxation, physical fitness, strength training. And what we did at that time, and that I think that was one of the reasons it was a success, was we had a huge multidisciplinary group. So it was doctors, nurses, physios, exercise physiologists as well, psychologists, and with that huge group, it was easier to implement that in the healthcare system. What we did afterwards, because we were also aware that it wasn't just in the healthcare system we needed to do something for these patients. So we created some patient societies afterwards that the patients could join training after they have been in our program. So we created a society called Proof of Life for young cancer survivors, also during treatment. They are all over Denmark as it is at the moment. And we created another one because after we did that, this was from 18 to 40 years of age. And after that, people that were older than 40 came to us and say, why is it always the young ones that have all the fun? So we created a society called PACT, Physical Activity After Cancer Treatment, which again was for various types of cancer diagnosis. And what we did was giving them a chance to train in our facilities after we left it. So during evenings, this group are capable of training, allowed to train in our facilities. So if we need to be successful in the implementation, well, we need, of course, some evidence. We have to show that it's beneficial, whatever we have given to these patients. And that's, well, in Denmark, we have to convince the healthcare system. In other places, you have to convince whoever is paying for that. But again, evidence is something you need. And well, I think in the Netherlands, you have a system close to ours, Martijn, but still you also have some challenges.
Yes, we do. I think the way things are in Denmark is fantastic. I recall your colleague, Julie, said at some point they were testing this football intervention in a clinical trial, and at a certain point in time she had to go to all the policymakers and say, will you please stop implementing that because we have not yet concluded the trial. So I think Denmark is exceptional. Having said that, I think we're doing quite all right in the Netherlands, but we do have of course issues with reimbursement, which is one of the greatest barriers. And I thought I'd share some successful implementations that we have in the Netherlands with you. But first, let me start off by saying, in response to the second question, is it healthcare or is it lifestyle? And of course, we all agree it's both. The question is, when does it become what? And I think one of the responsibilities we have as healthcare professionals is to help people who do not have the skills or the self-management skills, or who have physical barriers to being physically active on their own, that's where healthcare should step in and take away these barriers that are related to the health condition. So it should be a sort of a continuum, I think. Now, some successful programs that are aiming to do that we have in the Netherlands is first a national network of cancer rehabilitation facilities. So we have this national guideline on multidisciplinary cancer rehabilitation. This is evidence-based to the best possible extent, and this means that this program is actually funded from basic insurance. So all patients who have complex health issues related to cancer or cancer treatment, they can join such a cancer rehabilitation program. We have a network of physiatrists or rehabilitation physicians who are trying to develop the whole field of oncology rehabilitation further in clinical practice, and we have lots of facilities in rehabilitation centers and hospitals who offer this type of multidisciplinary intervention. Now, what helps these cancer rehabilitation programs to be successful is that the guideline also gives recommendations on how to screen people and how to refer people to those programs. And that's not to say that this goes without any friction or any problems, but you know, the roadmap is laid out. Having said that, this is only for a few, a very small group of people who have the really complex problems, and this is not the majority, obviously. So we do serve those with complex health problems, I think, very well, but there's still a whole much larger group who does not who is not entitled to this fully reimbursed cancer rehabilitation. One specific example that I would like to point out is one that we have implemented at our own institution at the Netherlands Cancer Institute, where we have such a multidisciplinary complex rehabilitation program for people with head and neck cancer, which runs alongside the medical treatment plan. So from the moment of diagnosis all the way up to the path of recovery and rehabilitation, there's a rehabilitation program to prep people for treatment, to help them through treatment, and to help them recover from treatment. And this is, again, evidence-based to the best possible extent. It's highly personalized, and because it's completely integrated in the hospital infrastructure, this works very well. So this is for the rehabilitation. Another example I think is interesting to mention is the OncoNet network. We have a nationwide network of physiotherapists. This is, I think, currently about 600 physiotherapists or so joining the network that we actually founded to support an ongoing randomized controlled trial, the PACES trial. So that was the trial I referred to earlier, and to get people in the trial to get their exercise interventions. We had a small network in the area of Amsterdam to deliver those exercise interventions. And having that network, it was quite easy for us to expand the network, and it now is nationwide, which means that we have almost achieved the availability of a physiotherapist who is skilled in exercise supervision for people with cancer within 15 minutes travel time of their own home. And maintaining that network, of course, is very valuable to make the care accessible. I think what also helps is that for this network, there are qualifications that need to be met. So physiotherapists have to have at least 70 hours of initial oncology training, and they have to follow mandatory refresher courses as well to stay up to date. So we have this whole cycle of keeping people specialized to a level where they can provide this supervision. I should mention that we also have even more highly specialized oncology physiotherapists in the Netherlands, most of whom are also members of OncoNet, but they can treat even more complex conditions still in primary care. And then the last example I'd like to mention, and this relates to what Katie said of how do we move from research funding or something as luxurious as what Morten has in Denmark with basic insurance covering it all. There's an initiative in the Netherlands which is called Tegenkracht, which translates as counterforce. It's a foundation to support people with cancer being physically active and to exercise. And they have established a very productive collaboration with the national police force. So what happens is that everybody who's an employee of the national police force who is confronted with a cancer diagnosis then gets referred to this foundation for exercise advice and screening and support. And this, of course, is very helpful to the patients, but it's also very helpful for the police force, because these are people who have very high demands on their physical fitness and skills. So this initiative actually helps these people to get back to work more effectively. And in doing so, this is, of course, attractive for the employer to be involved in. So the employer pays for the advice and they get their employees back to the workforce quicker. So I think that's a very interesting model for implementing this sustainably. Make the employers a partner in helping their employees to move through cancer. Yeah, so those were the examples I think stood out most in the Netherlands. Nicole, do you have additions?
I think you all have done a marvelous job of articulating these various and different models and examples that have been successful. And I think I'll just summarize in the interest of time and say, what I hear across each of these examples is really the optimal outcomes happen when we're able to work together across disciplines, when we're able to work across settings. What I've heard from each of you portraying these very successful programs are meeting patients where they're at. I truly believe that we need to facilitate the rehabilitation intervention to alleviate many of the impairments that individuals experience, so that in fact the patient can exercise and can be more active or can advance their physical activity. And I feel as though if we're trying to implement one without the other, we're not going to be as successful, and we're not going to be, the individual's not going to experience as optimal outcomes as they potentially could. So I think some of the most successful programs are those that provide a handoff from an exercise professional to a rehabilitation provider when an impairment pops up, from a rehab provider to an exercise clinic when the patient's ready to move on, or to a home program when they're ready to be more independent. So I think that balance, and I think that's the critical theme here in successful programs. So I'll let us go ahead and move on, Kevin, because we still have a lot of good stuff to talk about.
Sure, absolutely. Thank you guys for that excellent discussion thus far. Before I ask the next question, I just want to note that we are taking notes on the questions that you all are posing to us, both in the chat feature, and there's a Q&A feature as well. So we're taking those down, and when we get to the general discussion, we'll try to prioritize and pose them to the panel. So let me now share my screen again real quickly and pose the third question, which is, now that we've discussed the challenges as well as provided examples of when exercise interventions can be successfully implemented, the next question is, where do we go from here? That is, what are the next steps that the cancer rehabilitation, clinical care, and research communities need to take to promote wider dissemination of exercise interventions with individuals with a history of cancer? And Martin, I think I'm going to direct this question to you first.
Thank you, Kevin. I think with the ACSM roundtable that Katie chaired, based on that roundtable, we published 3 papers on integrating exercise into cancer care. And I think that was a good effort to inform all researchers and clinicians of the current state of science and practice and where to move from here. And we have had a lot of discussion going back and forth on what should be the first step to move this further. And actually what it boiled down to, in our opinion, was that we have to take this first very basic step of getting every oncology clinician, every primary caregiver, so that's the doctors, the nurse practitioners or nurse specialists, or the nurses, to regard exercise and physical activity behavior with the same importance as they would vital signs and psychosocial distress. So what we suggested was to follow these steps, which we summarized as assess, advise, and refer. And I think if we get all the clinicians to do just that, we will have made a huge step forward in many places. And I think one way of doing that is to try to get these questions or this workflow of assess, advise, and refer to integrate that into the structure of healthcare. So one of the ways that we've discussed that it might be possible to integrate this into the electronic health file so that it sort of naturally pops up in the discussion. It's very important not only for the advice, but even the docs are expressing an interest in how physically active are you, or do you manage to stay physically active? That sort of conveys a message to a person that it's actually something that's very important to do, and to try and keep doing, and to ask for help if they need help. I think that's the first major step. Then the second thing is, and this is I think a call to action for researchers, if we want to advise and refer, and as I pointed out before, and we've discussed along the way, we need to sort of triage people to the right type of programming at the right time. So we need tools to do that, and there currently are not many of such tools, and I can't think of anyone that has been validated for this particular purpose in an oncology setting and that has been widely implemented. So there's a lot of work to be done there. So I think that's something the research community could take up. And then the last thing I think is important is that if we have these tools, if we ask patients about their activity, if we can triage them into the right programming and we want to refer them, referrals should be as easy as possible. So as Nicole pointed out, we should have these handoffs between healthcare and community service and back and forth. And to do that, I think it would be very helpful if you would be able to put a face to a name. So on a local level, I think it's very important that networks are developed, connecting all these different services that are regionally available to one another, and to structure that process. And I think there's not a one-size-fits-all solution to this, because it will depend on the type of hospital, the type of people that they serve, the socio-demographic characteristics of their population, the setting that they're in, be it rural or urban. So I think local solutions need to be developed. And I think one of the most important things to do is to share the efforts of those local initiatives among each other, so we can learn best practices of how to do this, because I don't think this is something that you can easily address in a randomized controlled trial. It's something that you just do and you learn by trial and error. And I think it's very important to share the successes and also the problems that we faced whilst doing that. Yeah, so I think I'll hand over to Nicole.
Thanks. I tackled this question a little bit more from the research perspective, with the mindset of the emergence of dissemination and implementation science. We have really seen a growth in that field, that there is in fact a science behind taking the good, strong evidence that we have that says, yes, there is efficacy in exercise interventions for cancer patients. We have evidence around effectiveness of models of care to enable exercise and rehabilitation. That the implementation piece of that requires us to use a more structured, more methodological approach to getting at implementation. And Martin, you mentioned workflows. I think looking across, what I see in the US and worldwide, there are a number of successful programs. We've outlined a number of them. And when we look at them, Katie made a great point. If you've seen one, you've seen one. But there are elements of each of those bespoke programs that are probably similar across programs, but we don't know that yet, right? So what are the workflows that have been successful? What are the policies and procedures? What processes did they put in place? What were the staffing models that they put in place? How did they develop relationships? Where were they located physically in a healthcare system or in a community? What were the policies that had to be changed to enable? Those are the types of things that implementation science can help us to better study. So looking across these successful programs, I would say, is a huge opportunity for us to learn about what is the best practice, perhaps, in implementing an exercise program. So that's really where my mind went to with that. I'd like to hand off to Katie, in fact, because I think she has some great thoughts here.
Yeah, I couldn't agree with everything you said more, Nicole. I think the things that I would add, I'm just going to be redundant because I think they're important, is that I think that we do need the development of a proactive registry, that if you have a program, it should be in the registry. And there should be some auditing of that registry so that if clinician X in Denmark or in the Netherlands or the US or in Spain or Australia, wherever, looks up a program on that registry, that they know that they're talking about something that has been audited by a body that is trusted by that clinician. I think that we have a huge issue with workforce development, and I think that it's a mistake for us to try to implement programs before we have that workforce in place. It's not sexy. It's going to take a really long time. It's going to require that we develop textbooks and coursework for undergraduates in kinesiology across the entire United States, et cetera, for us to be able to have more people who are coming out with undergraduate degrees in exercise science, kinesiology, et cetera, who have some idea what exercise and cancer is about. And then I'm just going to say it again, policy. I think a major next step for us is to evaluate the policy landscape. I think right now, policy is one of those things that, people like me who made their lives and a livelihood doing clinical trials, I say, oh, change the policy, everything will be fine. Truth is, there's a whole lot more to it than that. And we really need to do a fairly deep dive into understanding the policy landscape that would potentially affect whether or not we could affect change in policy that would alter implementation of this evidence-based lifestyle health care intervention. I think I'm passing it on to Morten.
Would be easier if I'm not unmuted, sorry. Well, there are two things I think that is important in this as well. And that is if we learn from other specialties. I mean, if we look at oncology, it's probably the specialty with most objective tests, unless we talk about functionality. Because when we talk about functionality, all tests are subjectively measured by the oncologist, the nurse, and that doesn't mean to be a problem, but it's probably not the health professionals I think would be the best to evaluate functionality. So let's say, for instance, you have to discharge a patient, and that patient lives on 3rd floor. Well, if they had a hip surgery and was an orthopedic patient, well, they will never be discharged without them walking the stairs. But if it was a cancer patient, the doctor will ask the patient, can you walk the stairs? No, the patient will say, and then they will get some sort of transport so they don't have to walk the stairs, and then transported up to the 3rd floor they live on. So the problem here is when we talk functionality, and especially within patients with advanced stage, some have really provoked that patient in an advanced stage can be active and do exercise. And when we tell them to do exercise, some say that why should they exercise? And again, we have to have focus on functionality. And the only way to improve your functionality is actually doing some exercise. If we ask patients what they fear the most, well, it's being dependent on others to help you, not being able to do the things you normally do, doing your daily activities of life. So we need to learn from other specialties saying that, well, if you have to improve your functionality, first thing is we have to measure that right. It's not okay just asking, can you walk the stairs? No, we have to measure that. We have to see that so we can prescribe the right type of exercise for these patients. And again, this brings me back to the first question, that we really need the oncologists to get on board looking at how we can get the best rehabilitation for these patients. Yeah, back to you, Kevin.
Okay, great. All right, we're going to move on to the fourth question, which I will show on the screen. Hang on one second. Okay. The fourth question is, a final issue pertains to the reality that individuals with cancer move through different phases of the cancer continuum, including diagnosis, active treatment, and beyond. As a result, the nature of screening, assessment, referral, and intervention can vary greatly depending on the point along the continuum an individual is at, as well as the setting in which they are receiving care and support. From your perspective, how can we help people with cancer and their healthcare providers navigate this complex journey? And Nicole, I'm going to kick this question to you.
Thanks. I'll also just remind folks, we had a poll question that just came up. So if you have a chance, you'll see that probably pop up on your screen. Please go ahead and fill that out for us. Kevin, you bring up, and this question is so important to cancer, because we're not just talking about people who experience a post-injury or post-surgical issue, right? This is a continuum. It's a protracted continuum. And that's why the ongoing reassessment is so important. And, you know, I've spent my career studying this concept of prospective surveillance, baseline assessment, repeated assessment of the individual, because I say this all the time, the prescription that I give them today for exercise or rehab, in 3 months, it's wrong. They need something different most of the time. So take them through 2 or 3 cycles of chemotherapy and reassess them. Their balance is different. Their fears and their confidence may be less. Their fear profile is higher. They don't have as much, they're not as strong, they're more fatigued. So the exercises that I give them early on need to change. And I can't emphasize then how important it is for us to continue that ongoing reassessment so that we can identify those changes. We've had some comment about tools to assess function in the cancer population. I would direct you to the Oncology Academy of American Physical Therapy Association. They've published 25 systematic reviews, I believe maybe 26 now, looking at and ranking the quality of the tools in different domains for different types of cancers to assess impairment. Things like functional mobility, issues with neuropathy, lymphedema. So what are the optimal tools? Those are available in an annotated bibliography for free on their website. And it's critical that we use those tools to help us reassess. And when we use that prospective reassessment intervention, we can identify when things begin to change and when we need to tailor the exercise program. You know, I think we have a captive audience here. We can't just give someone a piece of paper, here's some exercises, right? One size doesn't fit all. But even if we assess that individual at immediately after they've started care or halfway through treatment, the exercises I give them today are going to be wrong for them in 6 months. So the reassessment is really a critical piece. The other part of complexity in this population isn't just that they're changing treatments over time, they're having different side effects over time, but different cancer treatments, different types of cancers, there's so many different nuances, right? The exercise prescription that I can give to someone with prostate cancer who needs weight-bearing exercise or aerobic conditioning will have to be very, very different for someone who has head and neck cancer, has severe radiation fibrosis, can't move their neck, and may have facial lymphedema with eye swelling. Can I give them the same gym-based exercise or tell them to walk in the community? Those are challenges that we as rehab providers and exercise professionals are very skilled at assessing and helping people overcome. So while I can get someone in an exercise program today, I want that reassessment in a month or in 3 months to see what changes now we need, what barriers have popped up because of the treatments, what do we need to change? How can we change breathing strategies, postural strategies, flexibility as they move through radiotherapy? So there is a lot of complexity to cancer. And I don't even need to launch into talking about many of the psychological and psychosocial issues that these individuals face. So even as they begin to recover their physical mobility and their physical function and capabilities, there's still a confidence issue that many of them face. There's still fear. And I'll just share with you a great story that always drives this home to me. I was working with a gentleman who was prostate cancer, and he was a younger prostate cancer individual in his late 50s. And he was incredibly active. He was a triathlete, in fact. And he was getting back. We're getting him through treatment, and he's getting back to running, and he's getting back to swimming, and he's biking, but only in his house. And I said, you know, John, when are you going to get out on the road on your bike? And his eyes lit up and he said, are you kidding? I have no confidence in myself getting on a bike on the road. I don't feel safe doing that. And meanwhile, you know, he's swimming 45 minutes a day, and he's, you know, working out at a moderate to high intensity. He's doing resistive training in the gym, but his confidence to do that activity wasn't there. So as we prospectively reassess individuals, not only do the treatments change, not only does the side effect profile change, the complexity changes over time, but so does the psychological consequence of the cancer and its side effects. And it just drives home the point. It not only is this not, you know, an exercise prescription, a blanket exercise prescription, one size fits all. It's also not one size fits at a time point. It does fit, but then it doesn't fit in 3 or 6 months. So that ongoing reassessment, I think, is really what we need to accomplish to overcome these complexities to keep people optimally moving. And I'm handing that off now, I'm sorry, to Martin. You can tell I get a little passionate about that. Need for reassessment and helping individuals progress as best they can.
Okay. Yes, you are obviously very passionate about that, Nicole. And actually, I couldn't agree with you more. I think it's very important that we have this structure where we can reassess patients at given time points to see what they need. The thing is, of course, how do you achieve that? And can you also tap into people's self-management skills to do so, and not only put that in the hands of a healthcare professional? I think it's important that we help people to find the help they need also on their own, so as not to be dependent solely on the healthcare providers. And one of the ways to do this, and I think this is a very nice initiative that we have in the Netherlands, is that the Netherlands Comprehensive Cancer Organization has this website that people, you know, patients and survivors can visit, and depending on what type of help they feel they need, they can find healthcare professionals who are sufficiently skilled to deliver just that type of healthcare. And I think having such a website is really helpful. I think, Katie, the registry that you just mentioned, that's not only a tool that might help us to find out what are the common elements of successful programs, but it can also help people to find programming near their homes. With OncoNet, we have something similar. So OncoNet maintains a website. People can just enter their postal code, they can find a skilled physiotherapist and see what he or she has to offer. So that's and that's quite labor intensive to maintain, but I think it's really helpful. The other thing I think is interesting, and I saw this, I glanced at the chat and I saw some of the attendees mention this, is the concept of patient navigators. And we've been experimenting with this at the Netherlands Cancer Institute as well. And these are health professionals whose main task basically is to frequently reassess patients' needs. So not so much, I think, their abilities or their physical capacity as such, but just discuss with them, how do you feel? How's your quality of life? Do you have distress? What do you need to move forward? And can I either give you some advice myself, or can I direct you to someone else who can? You know, we're still in the process of evaluating this scientifically, how good it works, but just from a clinical perspective, people are very enthusiastic about this, and not just the patients, but also other healthcare providers, because they realize that they have a lot of work on their hands and they can't do it all by themselves. So, you know, even though we try to make it simple, assess and refer and so forth, there are a lot of issues to cover, and not just exercise, but also these psychological distress issues that people might have, or just practical issues. And patient navigators can be a very good way of trying to tackle that. So that would be my additional suggestion there. And I'll leave it at that and hand over to Katie.
Okay. So I have a different sort of comment that I think is important in the context of this discussion. And that is, I think it's exceedingly important that we remember not to ask too much of oncology clinicians. And so this is a catch-22, I think, because we are all extremely passionate about assessment, reassessment, appropriate advice, behavioral support, having the right program for the right patient at the right time. And at the same time, I think that if we ask for more than about 60 to 90, maybe 120 seconds of time on the part of the medical oncologist, the radiation oncologist, or the surgical oncologist, or their nursing staff, it becomes a question as to whether or not they would be willing to do whatever it is we're asking them to do. So what can we ask them to do, and how can that work? And I think that this is where we come back to the partnerships and the co-location that we talked about earlier. And I think that if we can get the physicians we can shape their behavior through CMA courses, through continuing education, to assess, advise, refer, 2 minutes, 3 minutes, very brief. And you know, the people who can go out for a walk, great, get them to go out for a walk. People who, you know, they don't know, they're not sure, those people all get referred on. And who they're getting referred to, that's the big question. Where are they being referred to? That's the big question. So those are my additional, and I think the last word goes to Morten.
Yeah, thank you. Well, you gave me the last word, but actually I agree with all the things you said. So, well, from my perspective, I couldn't agree more about don't put too much on the clinician's shoulders, and it's something that we get back to through all 4 questions is, well, we need to educate people to see exercise or see functionality from another angle, that it's just some sort of exercise these patients are doing. And well, I think a navigator that can help patients to get some individual tailored something they need specific, because something we need to know is that being active, if you haven't been active before you got a cancer diagnosis, well, who would thought of being active then? I mean, it's very preference specific to join an exercise program. Sitting on a stationary bike, doing some machines or stuff like that. If you have never done that, just because you get cancer, why should you start doing that? And if you ask the oncologist, they might tell the patient, well, we don't know, but, and that's where we need to educate why this is so important. And it gets back to one of my main topics, and that's functionality. If you want to keep being active, if you want to keep your function, if you want to do the same thing you're used to, you need to do some sort of exercise. And maybe we have to call it something else, that exercise, but as I said before, that will provoke some inactive person saying, I will never do exercise in my entire life. Then we have to find a new word for it and train them, or whatever we could be capable of, because the sooner that, yeah, exactly, the sooner they would learn that they can actually keep their functionality if they move, if they do some sort of exercise. Well, they will quick notice that they actually get better. And I think I saw some of the chat where someone were asking about rehabilitation, and that's another thing we could learn from other specialties. I mean, if you're going to have a hip surgery, you are told to do specific exercises before that operation. And suddenly clever people start looking at cancer patients saying, oh, maybe we can learn from that. And there are excellent studies out there, especially within lung cancer, early stage lung cancer, that they can actually show that they can reduce the amount of days they are in the hospital after surgery if they have the proper prehab. But I think, Kevin, maybe we should go back to some of all the questions. I've at least seen 10 really interesting questions. I hope we can get through some of them.
Thank you, Morten. Yes, we have had a lot of interesting questions, and we have a crackerjack team going behind the scenes, which has been collating. So I want to thank Melanie for collating some of the questions and actually identifying some themes. Melanie's Katie's postdoc, so we're happy to have her join us on the panel. Before we get to those questions, I do want to mention one person wrote me and said they were having a hard time keeping up with our English. We should recognize that not all of the attendees are native English speakers. So I do want to mention that we are actually going to transcribe the entire discussion today. Not only is it being recorded and archived, but it will be transcribed. So if you feel like you can't keep up with the speed at which we're speaking English, if it's not your first language and you'd like to read the transcription later, I think we may be able to make that available so that you can slow down and digest our words at your own pace. So let me quickly move to the next section here at the very end, which is just our general discussion. And I'm going to actually identify the questions. Here we go. So we kind of grouped these, Melanie, I should say, grouped these into sort of the big themes that we saw. And we saw 5 themes emerge from the questions from both the Q&A and the chat feature, including patient barriers and motivators, exercise training for patients, cost savings, working with stakeholders, and training for professionals. So maybe we'll just start at the top and kind of maybe we can ask the panelists to comment a bit more on barriers and motivators. It looks like there was a question, how can we support patients with financial concerns that can be a barrier to access physical therapy services and completion of recommended treatment regimens? And also a question about referral being a big barrier. And wanted to see what the panel thought about that. And I will stop sharing my screen so you can see the presenters. Anybody want to tackle that first question about barriers and facilitators?
I'll start just with some insights that might be helpful. And I'm not sure what part of the world that question came from, but there have been what I've seen, and I would call them facilitators, around getting those referrals through enabling your electronic medical records. There was a really nice paper that was written by Daniel Santamina out of the University of Toronto, Laura Rogers, who's here in the US. There was a group of them that came together and they talked about how they implemented guideline thresholds within their electronic medical records. So I am happy to find that link and to facilitate getting that up in the chat box for you. But I think a way to generate the referrals, there are guidelines worldwide from oncology professional associations that highlight if an individual has clinically significant fatigue at a level of 4 or more out of 10 on a visual analog scale, that's an indication for management of fatigue. And so to be able to embed those thresholds into your electronic medical records, if your physicians use decision support tools in the oncology setting, primary care providers as well. But we need to look to those guideline thresholds what is the level of toxicity that's reported with neuropathy that's functionally disabling and should indicate a referral. So I think there's an opportunity, and I don't think we in rehab have leveraged these guidelines enough. Take a look at the NCCN, the National Comprehensive Cancer Network's guidelines for survivorship care. The American Cancer Society guideline for head and neck cancer. There's a remarkable amount of guideline recommended approaches that are embedded in these guidelines and that suggest at this level with this impairment, refer to PT, OT, cognitive therapy, exercise professionals. These are articulated in the guidelines. I don't think we're familiar enough with those. I don't think we're leveraging those enough across not just rehab, but also to facilitate that movement toward the exercise professionals. So I think that's one strategy, and I'll pause and let others comment on that.
Yeah, so actually I'd like to comment on the question of the financial barrier, because I think that's a very significant problem, and it may not be ours to solve completely. You know, if you want some kind of exercise supervision and access to a facility one way or another, somebody has to pay for it, right? So that's always going to be an issue. Then again, I think there are many people who might benefit from advice, examples, things they can do to improve their self-management, and we can achieve that, you know, outside the gym. So there have been some research initiatives, and we are currently running a study on one of those in our hospital as well, where self-management tools have been developed that run via the internet and that are completely or largely algorithm driven. So patients put in their you know, they complete their patient reported outcome measures, they put in their wishes, their goals, and these programs then respond with tips and with concrete advice, or even, you know, a little movie showing you how to do a certain exercise. And that's a very low level way of providing people with a little help with their self-management and maybe improving their self-efficacy to embark on this exercise journey. Another one, and this is a bit higher level, I think, but still relatively cheap, would be some form of some sort of blended form of this. So e-health or remote e-health delivered exercise intervention from an exercise specialist or physiotherapist from within the hospital to the patient's home via electronic devices, be it the internet or mobile devices. That's relatively cheap, I think, to implement, and it's also very accessible to many. So that would be one way of doing it. But still, these applications also need to be, you know, implemented. They need to be sustained. They need to be developed and tested. So there's always going to be a cost issue. And at some point, I think, being civilized countries, we as societies should just find a way to pay for it. But you know, that's a whole difficult discussion, I think.
Well, if I should go on with that, Fred, saying that if you look at financial thing, as I said before, in Denmark, we have a tax system that it's all free, but we still see some sort of inequality in who is getting rehabilitation or treatment as it is, because it looks like patients with a short education compared to patients with long educations are not getting the same amount of rehabilitation or treatment or whatever we are offering in our healthcare system. So even though we don't have the financial problem here, well, we still need to target whatever we are giving these patients to a patient that actually understands what they're going through. So if we want to do rehabilitation, well, we need to get the rehabilitation at a level where people can understand why they're doing it and what's the reason of doing it as well. So it's not only the financial problem that could be a barrier here, it could also be that we as health professional might mirroring. So if we meet a patient with the same level of education as ourselves, we tend to be better to explain what the treatment or what the rehabilitation is about. So patients that don't have the same level of education don't think it's important to get rehabilitation. So if you take the financial part out of it, we need some sort of system where we have a measurement to find the proper needs of. So when we try to investigate what sort of needs they have for rehabilitation, we need some sort of a tool to still be general, but still again be individual. So it's not only the financial part that can be a barrier here as well. It can also be, yeah, the inequality that could be in the society.
I think you're getting at a really important point, Morten, and that is when we say financial, there's cost, right? There's cost associated with a service, with a person giving and providing this. So we have to assess that. What is the cost? But then there's also value. And that's the other piece that I think you're getting at is how do we articulate the value for the cost outlay that we're going to provide, the service, the hours, the time spent, the equipment that we need, the cost associated with providing that. What's the value? And you alluded just very briefly in your earlier comments to some evidence in the lung cancer population showing that with prehab, individuals spent less days in the hospital. That's value. There's cost associated with that we can show we mitigate. It's also value. That patients have less complications after the surgical procedures. You know, they go home quicker, they tolerate chemotherapy better. So I think if we're looking at some of these, how do we show our cost effectiveness? It is when we say we need people to see exercise professionals, see rehabilitation providers, there's a cost outlay. We have to be able to show the value for that outlay. Do they go back to work faster? Do they tolerate chemo better? Do they survive longer? We haven't answered. Those are really great and important questions for researchers out there to think about. Do we change the course of the disease with our interventions? That's where we need to be sort of looking forward and going to next.
Yeah.
Great. Well, maybe we can move on to the next big category, unless anybody wants to jump in on that right now. If not, I'll go ahead and share this screen. So this was the second sort of theme that was identified within the questions around exercise training for patients. And some of the questions had to do with, all right, got to minimize this so I can actually see this, sorry. Views on virtual training during the pandemic. Someone asking a question about prehab focus as well as preventative oncology. And then perhaps failure should be addressed at the point of diagnosis or risk assessment. Ways to improve long-term exercise adherence in the cancer population. Conditions that are seen in cancer patients following orthopedic rehab. Guidelines, and so on. So that's a lot there, but I'll let the panelists decide how to jump in, but feel free to pick one of those and talk about exercise training.
I'm going to jump right in for the first one so that folks on the call, because there's a lot of people on the call, know that a survey is being developed. I believe there's somebody who's actually listening in right now, Keith Thrain-Borowski, who he and I are working together with a small team to put together a survey that will be going out as broadly as we can get it in order to understand what people have done to respond to the COVID crisis and how people's in-person interventions have been altered. On what basis did you make decisions so that we can publish something that people can then point to as here's the best practices, here's what the field generally is saying we should do for virtual. I personally have funding in the area of doing virtual exercise intervention in metastatic breast cancer patients. And I actually think that we can do a whole lot more virtually than what we might have thought in the past. And I think COVID has shown us that. And I think that's a really, really good thing. I think that helps answer a lot of the questions that we have raised in this webinar. So I'm going to stop and let my colleagues answer some of these other questions, but I just wanted to jump in with that a little bit.
And I'd just like to second that, Katie. I think the whole COVID situation has kind of jump-started the whole e-health and tele-rehab movement. And in my experience, there's been a lot of reluctancy on the side of healthcare providers to actually take up this e-health rehabilitation more than it was on the side of the patients. So this might actually bring us something good in that regard.
Yeah, I'd like to address a bit around patient activation and motivation. I've learned a lot in the last year working with a group of professionals and experts across disciplines towards developing this screening for triage. We identified 5 domains that were important to assess an individual at baseline. And we published this in Cancer just in March. Karen Basin-Enquist, who's a researcher at MD Anderson, was a part of this group. And it was fascinating to learn from her and her research about many of the personal and behavioral factors that drive individuals and how we can better assess those to help us promote better adherence and buy-in to an exercise program. Anna Campbell, also who is with Macmillan, speaks to their assessment process when somebody comes into the Macmillan Move More program. And Anna said, and it was just so striking to me, she said, you know, we ask people if they're interested in exercise, and if they say no, then we just let them go. Because if they say no and they're not bought in, why are we going to try to force this? And I feel like sometimes as providers, right, healthcare providers, well, we have to fix this. You have to come in and see us, and there has to be an intervention. But if the patient isn't ready to receive that information, if they are not activated towards the behavior or interested in the behavior change, it was kind of freeing for me to learn about some of these strategies, to just say, and again, it goes back to follow up with them in 3 months or in 6 months, because their attitude may change, their perspective may change as they go through treatment. They may be more receptive, but if the receptivity isn't there, and there are great tools that are out there to help us assess things like self-efficacy and motivation and confidence. And we've got to start holistically incorporating those, I think, along with our assessment of physical performance and endurance and strength, so that we can really identify the factors that are either drivers or barriers for our patients. It's that body of evidence, I think, should be, we really, as rehab and exercise professionals, should really look to dig into that, I think, to a greater degree, and implement it into our assessment and our practice.
Great. There's another category around cost savings. Let me share my screen so we can all see the question.
So Kevin, I'll say we're at 2:28 p.m. Eastern time, so we're almost at 90 minutes. Let's go ahead and address some, because this is such an important question, but let's say that we'll probably make this our last question.
I agree. I was going to suggest that. Thank you, Nicole. It looks like there's a general question about cost savings to the healthcare system when oncology is implemented. I'll speak to that, and then this will be our last question. Again, I want to remind everybody that the session will be recorded and archived, and we will be making that available as soon as possible.
Yeah, I'd like to react to this question. There are actually very few cost-effectiveness studies. We did a review of cost-effectiveness studies for the guideline, and actually, I think in general, there's just too little evidence to support that it is cost-effective. It's more, you know, it's common. It feels like a common sense thing to say, but there's very little evidence to support it. Having said that, the Dutch Cancer Foundation has had a consultancy bureau draft what's called a societal business case, in which they demonstrated that with regard to just physical fatigue resulting from cancer treatment, implementing an exercise intervention such as the one that we practice in the PACES trial, for every euro, that's our currency, for every euro that you put in, you get on a societal level somewhere between €1 and 10 cents and €1 and 70 cents out. And this goes into things like people consulting, less frequently consulting healthcare providers because of the issues that they're experiencing. Things like being able to return to work for more hours, and all those issues that go with being disabled due to your cancer or your cancer treatment. But these business cases and even the cost effectiveness studies that are available, they are driven by a lot of assumptions. So I think we really need to do proper cost effectiveness studies to make this point and get this across.
Yeah, I appreciate that you've done that work, Martin, and looking at systematically reviewing across the literature. I've seen, I'll call them again, sort of one-off cost assessments of interventions based on a specific impairment. Again, we feel like it's intuitive. If we do rehabilitation, we do exercise, we implement this early, we prevent the downstream effects. We need to demonstrate that. And, quite frankly, I think our evidence base has been maturing. And I think we are matured to the point where we now need researchers, instead of your next randomized controlled trial on an intervention, an exercise intervention, just looking at endurance and strength outcomes, what does it do to the patient's level of satisfaction, their return to work? Encouraging our researchers to look at some different endpoints in addition to the physiological endpoints. Health services research. There was a great article just came out recently from Mackenzie Pergolotti and a large group of professionals in the journal Cancer that recommend a health services research agenda for cancer rehabilitation. And much of these endpoints, we published a cost analysis looking at prospective surveillance and early management of lymphedema when it's in an early stage. And we modeled that and found that it's cost effective to put out the cost to have a healthcare provider, a physical therapist, see breast cancer patients and prevent that progression. It's cheaper to do that than it is to treat more progressed lymphedema. But those are just, again, they're one examples, one impairment, one direct cost model. We really need a larger effort. So I'd encourage you as researchers to look towards those endpoints, incorporating those endpoints into your research. Days in the hospital, time tolerance to chemotherapy, infections postoperatively. If we can show that we reduce those are indirect cost endpoints. I think we just have to think differently about how we measure success in our trials.
True, but on the bright side, there are several ongoing studies at the moment that actually have proper health technology assessment incorporated. We are currently running a European trial for exercise in women with and men with metastasized breast cancer that Katie is actually on the advisory board of as well. And that's a large trial that also incorporates health technology assessment of the intervention. And I know there are quite a few other studies being conducted as we speak. Yeah, we should be very much anticipating those outcomes that will help make the course. Yeah.
Thanks, Martin. Katie, Morten, any closing thoughts before we end the session?
We have a lot of work to do. This field is in a wonderful, wonderful place. And I think we're at some kind of interesting tipping point. So it's an incredibly exciting time to work in the field of exercise oncology and cancer rehabilitation. I think what I am most, proud of is that I think we are well past the moment where it's either or. Where I think that we've all, come to a clear agreement that we need to work together and that we all benefit from working together. But we have an awful lot of work to do, and we'll need to be coordinated. I would ask that anybody who is interested in being a part of trying to move this field forward. Take a look at the Moving Through Cancer Initiative website. And if you're interested in being helpful for any of the many activities we're doing there, please be in touch with us. We have a mission. Let's achieve that mission. I think we all agree with that mission, that we want exercise and rehabilitation to be standard practice in oncology by 2029. We can do it together.
Thank you, Katie.
Yeah, but I totally agree, of course. And I want to add from Nicole that I want to encourage all researchers that do qualitative research and maybe dig deeper into experiences of patients. Even though we've talked about getting the oncologists, the clinicians into this, and they only look at hard endpoints as survival, but I think it's important to get the patient's voice in this as well. And there's some really good qualitative research showing why patients are doing this, and it's actually worse for the patients to be active. So, yeah.
Well, I think that's a wonderful note to end on, to really include the patient voice, because at the end of the day, that's why we're all here, to improve patients' quality of life and functionality and longevity. So thank you for that statement, Morten. And I want to thank the entire panel, as well as Melanie, for all the help that you've put in and all the hard work in preparing for this. And we look forward to continue to work with you. So thank you, Nicole, Morten, and Katie, and all the attendees as well. We really appreciate the interest, and we'll see you again soon.